Hello, everybody. My name is Emily Baldwin. I'm a Harm Reduction Nurse Educator and registered nurse here at Allegheny Health Network in Pittsburgh. Most of my experience, I've worked at a syringe access program in West Virginia for about 10 years or so. And now the past couple of years, I've been up here at Pittsburgh working with the community here. I started working with Prevention Point last year at their needle exchange sites. We are partnered with them, our health system and Prevention Point partner to do an MOUD clinic that's low barrier and that's on mobile sites, on their mobile sites. So I kind of figured out a way to work with them a few days a week. So I get to do some wound care with them and work with the community. So we'll get started. Just a couple of things. I kind of threw these slides together a little quickly, so there's not a lot of stuff documented or cited in here, but I swear I have permission to use all of the infographics and pictures and things like that. I just wanted to make sure everyone is aware of that. So I know you guys are probably already familiar, but we'll just kind of run through this really quickly. What is xylazine? So we're mostly hearing it called tranq. That's usually the term that we're hearing the most of. It is non-opioid animal tranquilizer causing severe prolonged sedation. So this is really complicating our overdose reversals. That's kind of the biggest problem that we're running into there with the sedation. Theorized that it's being added to extend the effects of the short-acting opioids. That's still up for debate, I guess. That seems to be what the case is. We have not seen it yet in this area not attached to any opioids. So it is usually with that opioid supply. No one is actually just selling xylazine or going to seek that supply. It was never meant for human consumption or repeated animal use. So even though it was a veterinary medicine and has some research for veterinary uses, it was always used as like a one-term or like a one-time kind of thing. And so there's not any research to show what the repeated exposure to it will do. Now that we've kind of seen that, I have a feeling if they used it in animals on a repeated basis, they would likely be seeing some of these wounds on the animals as well. So it does have some severe CNS, cardiac, and respiratory effects. Causes a lot of vasoconstriction, making it very difficult to get oxygenated blood to the tissues. And that seems to be most likely what is causing the wounds to really to have that tissue really dying at the site. So where do the wounds start out? They start kind of like these little blisters, almost like bruises. So you're probably seeing a lot of those. And some people, that's as far as they get. They kind of do that. They might open up and turn into a mild scab and then go away. But for most people that are getting the wounds, they will just start, that dead tissue will just start growing. And then it kind of takes a misshapen border and then can kind of do all kinds of different things. They can grow. I've seen some that go really deep, but don't get very big around. And I have seen some that are just kind of spread just a few layers and just kind of take over like a larger surface area. They have been mostly in the limbs, but they can appear anywhere. I had not seen any on limbs or on non-limbs until recently. I saw one on a neck, which was very concerning. They have been reported with people who are smoking and snorting drugs only. So and on injection sites. So it is not necessarily a matter of injection or missing injections. That seems to be a misunderstanding there. They do seem to be more common and more likely to happen if you're injecting and you miss, but we have seen people who don't inject at all that are definitely getting them. We've had some people who are snorting as well who have started to, they can't see them, but when they blow their nose, sometimes they're blowing out some of that dead tissue. So something is happening in the nasal cavity. And some people are actually injecting and using the same supply and not getting any wounds. So it's kind of, that's really one of the big unknowns is why some people are getting them and why some are not. I'm not exactly sure yet what is causing them, likely the vasoconstriction.
Because my phone, if I don't get a receipt showing that I bought my phone may be useless.
And then so often there's going to be visible eschar, which is like that dark, black, thick dead tissue. It looks like a scab kind of, but it's just dead tissue that kind of adheres to the wound bed. There's usually, that's kind of the telltale sign. If there's some dead tissue there that looks like that it's likely a xylazine related wound. They can, this is fairly new. I've started seeing this because we were a lot more used to dealing with abscesses. People get them, we've dealt with those for a long time. People who use substances are used to dealing with them. But I have seen a couple now that were regular abscesses. They popped open, they drained, and then after they drained, that tissue started dying. So we've got some people now who might start with abscesses and they don't look like they're going to be xylazine wounds. Looks like a regular abscess that as it starts to heal, that tissue starts dying. So that's pretty concerning to see that they're kind of starting one way and then turning. So these are just some basic pictures. So this is one here this is sort of how they start. They look like kind of a bruise. And then that top layer kind of peels off and just starts to eat away at it. To the right here is what I'm seeing more of is lots of little ones rather than bigger wounds. I've definitely seen some big ones, but more commonly it's a lot of these smaller ones. Just to keep that in mind. And sometimes we do know that some people have been able to avoid them opening up and the tissue dying from when they're at this kind of bruise state, keeping that very moisturized and going ahead and starting to moisturize it and cover it. And that seems to have helped for some people. Most of the time by the time they get to me, they're not in that state anymore. So I know this is very basic for everyone. These are I pulled some of this stuff from the stuff I use to educate patients. So it's a little simple, but helps us just kind of get through it here. So these are the 4 basic steps that I just have everyone do. You want to make sure there's no infection, you clean it, you moisturize it if it needs, and then you cover it. So we'll kind of go through each one of these here. So checking for infection, anytime they have a history of recent fevers or chills, there's likely some kind of systemic thing going on. Might not be related to the wound, they might have something else going on as well. The redness, warmth, swelling around the wounds and beyond. The wound beds are all pretty gnarly looking, so it's kind of hard to decipher infection just by looking at the wound. But we have seen that most of the people that end up needing antibiotics have some level of cellulitis around the wound, where it's actually spans not just like right around the wound border, but kind of like the whole area gets really red and warm and inflamed. So that's kind of what's been triggering antibiotic prescriptions, just kind of if they have that going on with it. Not so much just what the wound bed looks like, because they're all pretty gnarly looking. They are odorous and thick yellow-green drainage. If they have those things, there's likely some infection there. But we can't go on odor alone, just because these are dead tissues that are forming here, so that has a death smell as well. So the wounds themselves already have a smell, even when they're not infected. So that's kind of been a little bit different thing to kind of watch for. But usually if it does have that infectious smell with that yellowish or greenish drainage, then it's likely got some infection in it. The wounds themselves, when they start, are not infected. They're just dead and dry. There's no infection in there. We're seeing that a lot of people would just go to the hospital when they were first getting them and just getting antibiotics constantly, and they weren't really doing much because they're not infected. But they take so long to heal, like weeks and weeks and weeks, that leaves an open wound that's there at super high risk of developing an infection at some point. So that's where the infections usually come later that we see them, but they are avoidable if we can keep the wound dressed properly. Any severe or worsening pain on or around the wound. So really worsening pain, because I've seen different levels of pain with them, depending on kind of how deep and what kind of tissue and cells are involved. So some people kind of don't feel them at all, and they're just like picking at them and they don't notice them. And then some people are in some severe pain where it's taken out a lot of tissue. So all of these things are sort of hey, you should probably seek medical care. But the things in the black here are things that we know we kind of recommend people go seek care, but they probably won't. If it's only one of these stages, we just know that they won't. So kind of be prepared for that. But there can be some very, very severe things. So any pain or decreased mobility in the joints around there could be like a very long-term problem. We don't want that infection or that death to get into any of that kind of tissue. Any live tissue pieces falling off. So we've seen a few of that where the actual like chunks of still healthy skin that are near the wound kind of fall off. The dead tissue is supposed to come off, so that will kind of slowly debride, but you don't want to, once you start seeing live pieces of tissue, that's concerning. Any exposed bones or tendons obviously are fairly emergent situation. Unfortunately, sometimes still people won't go to seek medical care. I worry about those. And then any newly developed numbness in or around those wounds or below them, just to make sure that there's still blood flow. You want to make sure that they're not going to lose that limb. So those things are like really very concerning. The other things are also concerning, but can also likely be treated outpatient and might be a little easier for folks to handle. The cleaning, so washing the hands, obviously, sanitizer, wear gloves if possible. I do give some gloves out for some folks if they're in a situation where they are concerned about their hands not being able to get clean or not have running water and things. So do give that in the kits sometimes. Cleaning the wound, all they need is it's mild soap and water is still the best thing. They don't need fancy wound cleansers. If that's all you have, that's fine. I usually, when I'm on the van, I usually don't have running water, so I have like a spray bottle of wound cleanser that just kind of helps flush things off, or just using saline. But they don't need anything super fancy. Definitely no peroxide or alcohol or any harsh scrubbing on them. Those are big ones. If they have access to running water, it's helpful when they're doing after they clean, just to allow that water to kind of flow over the wound. That seems to kind of grab any of those loose pieces of eschar or dead tissue that need to come off without causing the damage to the wound bed. They'll just kind of, they're ready, they'll just sort of flow off of there. And then most times I tell them to allow to air dry before you redress it, just because most bath towels and things like that are dirty. So you don't want someone to grab like a dirty hand towel and dry their wound area with it. If you have some gauze or something and you're the one doing it, that's fine. You can kind of tap that dry first, but air drying usually seems to be better, so you don't get that stuck underneath there. So the moisturize if needed. So we know that when wounds heal, they need to kind of have a balance of moisture. They shouldn't be dry, but they shouldn't really be too wet. For the most part, these are very, very dry wounds, so they're likely going to need some moisturizing, especially if there's a bunch of eschar or that dead tissue on there. That moisturizer really helps to debride that. So around the wound, the area that's still healthy, kind of in between, like those ones that sort of had all those pinpoint ones, all that area in between, you want to kind of use some A&D ointment, which is just diaper rash cream. It's basically just Vaseline with vitamin A and D in it, or the petroleum or Vaseline kind of gel, just to keep that skin moisturized and help protect it. And then the wound bed, which is all like the area inside the wound border. So we would apply Meta Honey, has been so far the most consistent thing that works, or a zero form, or a petroleum, but never all three, because that would make it a little too wet under there. The Meta Honey you only really need on the areas that have a lot of debriding needed, where there's a lot of thick black eschar still left, or a lot of slough that's kind of that old eschar that's sort of getting white and getting loose. And partly that's because it's so expensive, so it's really not recommended to. You don't need it on every single wound, so really kind of saving those for those really, really thick areas of that need debrided. If I'm doing them, I will usually apply with a sterile swab of some sort onto those eschar areas. But either do it that way, but if you don't have the supplies to give those sterile swabs as well, then you want to just use a non-adherent pad, put the Meta Honey on the pad, and then apply the pad to the wound site. The pad should also be cut to size of like roughly the size of the wound, so you don't get ointment all on the healthy skin as well, because you don't want that to start breaking down. If you're using the zero form, that should also be cut to size, which can be a little difficult because it's sticky and ooey gooey. If you've ever messed with it before, it can be hard to cut. But that's, again, you just don't want to over the wound border too far, causing more breakdown of the healthy skin. And then the petroleum, which is just Vaseline, that should be applied to the non-adherent pad and then put on cut to size, the same as the Meta Honey. It's also okay to put those on areas of the wound maybe that don't need as much debridement, but just kind of need help staying moist. So Vaseline is probably, you get some petroleum gel, that's like the best thing for it so far. It's most consistent, you need some of that. And then we cover and wrap them. So covering with non-adherent gauze, I would definitely get some Teflon, like that's name brand of it, but the non-adherent gauze. Some people don't like it as much because it's not as padded, but it does absorb quite a bit, and it helps with the removal of the dressings because these wounds tend to dry out so quickly. Regular gauze will get stuck to them. And also use non-woven gauze. The woven gauze has too many fibers that can really get stuck down in there and hard to get out. If anyone ever has a hard time getting a bandage off, just get it really wet, run it underwater or something like that when you remove it, and that can help. Um, some that they I have not seen too many that drain too much. They tend to skew very dry. But some of the larger ones that I've seen that cover more surface area tend to be a little oozier, not necessarily with infectious fluid, but just kind of serous fluid that's kind of draining out of them. So sometimes they might need an extra layer of gauze there just to help absorb some of that. I've used ABD pads sometimes, they're the most absorbent, and they're nice and padding, so they help protect the wound a little bit. And then you're going to wrap loosely with some conforming stretch gauze or Curlix. That's just like the rolled up gauze. And then also have an outer bandage, which could be either Coban, that's like a self-adherent, or reusable ACE bandages. Those are nice because they are reusable as long as they stay clean. And the Coban can be a little costly as well. So this is one of a larger one that did heal. So a lot of them that we're seeing are kind of coming in sizes and changing size and shape as they heal, and then might add some of these might merge together and become something else. But then they do heal, but the scars are pretty permanent. There's definitely going to be some scarring that will be sticking around. If they're too deep like into the tissue, there might have to be some kind of intervention to get some kind of packing or some kind of a wound back, even for some of the bigger ones, to really get that wound to heal properly from the inside out. Um, and get that tissue to reform. But for the most part, they're just kind of leaving like some divots, and then that skin will kind of reform over it. But it is been some deformities in the scarring. So here's some. This is a much more complicated one that's larger, and as you can see, this graphic here sort of shows the different areas of it. So these actually show this shows some areas where there might need to be different things done in different areas of the wound when you dress it, and that's very difficult to try to explain to patients when they're taking stuff home, and it can be difficult to do on site as well. So really, some of these blue areas, like this would be like the black eschar, that really thick stuff. This here would be some of that. That's where we would put that meta honey. And then some of this yellowish stuff that's also non-viable tissue. It's called slough. It's just it's the process of dying and just needs to fall off. That would be fine with just some Vaseline. It usually doesn't need the harsher things or the stronger things like the meta honey to get it off of there, because it's not really attached quite as much. And then the granulation tissue would be all this like nice red stuff in there that's trying to make new cells and looks good. Um, so sometimes we might have to treat the whole wound as several different wounds. And then once you've applied the ointments and things, you can kind of just slap a big piece of non-adherent pad over the whole thing and then wrap it up. But the ointments are kind of gone where they need to go. The biggest issue for me is that I don't know if I'm going to see somebody again. I don't know if they're going to come back to site. So I try to give out as many supplies as possible, but it's unclear how long those supplies are lasting, because I don't see them regularly, and then the wounds will start to get dried out again and whatever. So if you're in some kind of regulated setting where you actually have access to people on a regular basis, where you're going to them every day, or um, we actually did some training at the jail, and they were in a unique position to really see the wounds every single day and get to watch them heal. Um, then it's a different ball game. But if you don't know if you're never going to see them again, who knows? But we all know how that goes. So this graphic is kind of the same sort of thing here. So just basically in the steps here, washing things off with whatever kind of soaps you might have, applying that vitamin D, A and D ointment to the healthier skin around it, the wound bed really needing to debride all of that non-viable tissue, using the honey on the eschar, and antibiotic ointment I don't really use, just Vaseline is fine. If that's all you have is antibiotic ointment, that's fine, because it still has that gel in there that will help keep it moisturized. But the antibiotic properties of it aren't going to do much for anything, and they eventually can dry it out a little bit more. So if you don't think they're going to get it changed in the next day or two, then you might want to stay away from those. For some reason, that's still like the number one requested thing. Everyone wants some antibiotic ointment. So it's always good just to have around, because it's fine for little minor cuts and stuff. But it's not really doing much for these wounds. And then the first degree dressing is really just that whatever's going to be touching the wound there. So we want to put some of that ointment there, and then the non-adherent gauze, so that doesn't stick to the wound bed quite as much. And then an extra ABD or an extra fluffy gauze of some sort over top of that if there's a lot of extra dip. And then rolled and then covered. So these are some of the tips I give to people because these are a lot of the problems that I run into with trying to kind of guide the wound healing. The picking at it, the dead tissue is number one. And so people know that wounds do heal better if there's not dead tissue on them. So, and people are not wrong; they know that. So they logically remove the dead tissue, and then my wound will heal better. But if it's not done properly, it will really cause more damage to that wound bed. Definitely opening up more areas for infection to get in there, and touching anything with your hands. So it's just lots of education trying to explain that to people. But they're not wrong. You do need to remove that dead tissue for it to heal. But the ointments will sort of do that at a slow pace and a proper pace, and then get down to that wound bed that can start healing. Protecting the healthy skin around the wounds by adding that is big. And if they have a lot of smaller ones, we use so many of those wrap things just because it's such a long healing period. People will start having skin issues if they're using actual adhesive band-aids all the time. They're having to keep something sticky over that area for weeks at a time, and that'll cause its own set of issues. So that's why we've been using a lot more of the wraps. Sometimes if they only have a couple of small ones or something like that, some large band-aids are fine just to keep them covered. I try to get people to cut their rolled gauze once the area is actually covered, just to space their supplies a little bit more, so they don't use more, necessarily overwrap it when they don't need to, and kind of save those supplies as best as possible. Keeping them in sealed bag, give the kits out in a sealed bag. Try to keep everything in there so at least it stays as clean as possible. And it's a lot of instructions and a lot of information for people. So I always tell them if they get confused, just moist and covered is the most important thing. Moist and covered. Covered is the biggest one. We don't want to let them get completely dried back out. It'll slow the healing process, and you're just given so much risk for infection in there. And then this one, I'm trying to get people to come back before they run out of supplies, so it doesn't get to that chance where it's been uncovered for a couple of days and now it's completely dried out. That would really just be a matter of how you're handing out supplies or what kind of outreach you're able to do to give out supplies. Luckily, our sites are pretty low barrier, so they can kind of show up at any of them. But unfortunately, insurances don't really cover these things. It's not really possible for you to kind of just write a prescription for some of these things and have them go to a pharmacy and fill it with their Medicaid or whatever, which would really take burden off of some of the smaller CBOs that are trying to cover all of this expensive wound care stuff. But we can get kind of creative about it. I also encourage people, if they ever end up inpatient at the hospital, to tell their nurses that they need to take supplies home with them. So if they open a wound dressing supply kit and don't use all the stuff, don't let the nurse throw it away. Pull it aside and let that person take all that stuff home with them when they're done, so they have extra things. Nurses don't necessarily automatically do that, so it would be up to the patient to kind of be like, "Hey, I'm going to need that. Don't throw it out." But that can help just to stretch supplies, as we're going through quite a bit of supplies. This is from Dr. Jawa at UPMC and Graken Institute. I don't know what exactly they're called. From Boston Medical Center. They do a lot of education things too. They made this 2-page thing, which I'm going to email you. It is a public file that you can have printed up. So I will send you that public link. It stayed pretty consistent with some of the instructions. It hasn't really changed too much. So we're just kind of sticking to those. So it's a smaller set of supplies to worry about and things like that. But I will send you these so you have them to stick in the wound care kits and stuff. I also have some lists made up of, I've broken my kits into, like, this is a large Meta Honey kit and a large Zero Form kit, with kind of instructions special to those. So I will email you those as well. They're all generic. You can print them off or change them or do whatever you want with them. And that's really all the slides I have, but I would definitely like to open up to questions. I'm sure you guys have some, and apologize for not having more pictures too. I actually emailed a colleague. I don't have too many of them, and she didn't get back to me in time. So I was hoping to have some more pictures for you.
Thank you so much, Emily, for that presentation. It was very, very, very informative. If anyone wants to ask a question, please just hit the raise your hand button and we'll go that way with it. Or you could put your question into the chat. Bernie.
Cool, thanks. Thanks very much, Emily. I have a quick question about the vasoconstriction and if it's exclusively peripheral vasoconstriction, or how does it possibly impact the body's organs? If the organs
I didn't hear the last part of that.
I'm checking on the internal body relative to organs not being perfused because of vasoconstriction, and if it causes some sort of temporary or intermittent sort of malignant hypertension in the body too, or is it just at the peripheral level? You're muted.
Oh, I'm so sorry. The wounds seem to be, since they are only in limbs, I do think that's because of just that final burst of these smaller vessels that are getting constricted. We don't necessarily know what it's doing inside the body. I know there are some cardiac implications with it, so that could be something that's happening because of that. That's kind of the big fear, is that we don't know what's going on inside the body. If this is what's happening at the surface level, like what's it doing to your organs and everywhere else that it's going. Also not understanding why they're showing up at the certain sites that they're showing up. Like, what about that one particular area is it that the vasoconstriction affected that area so much, and so that tissue starts dying, and not the tissue over here that's also very far away from your heart and on these small vessels. I think there's just a lot more research to be done. I don't think we know all of that yet. If I find anything, I'll surely send it.
Cool, thank you.
I don't know if there's any old school health professionals too on here that are still using wet to dry dressings. So that was the thing that is not really recommended for most wounds anymore. It's kind of when you get get saline or something on a gauze and put that down in the wound, and then as it dries, it kind of pulls that dead tissue out. So when you remove it, it comes out. It's pretty painful. It's not usually recommended for most wounds. We've had, especially the ladies in the jail, the nurses there said that that's what they've been doing, and it's been helpful. And I can see how it would be if you have access to that person every day and you're able to change that wet to dry on your own. You wouldn't want that to necessarily get so dry before somebody rips that off of there. It would be very painful if they did that on their own. So I don't recommend it if you don't know if you're going to see somebody the next day or not. But they have had some success with that too. And I also like to just ask patients too, like, what have you been doing? Has there been anything that's worked for you that you've been putting on it? And for the most part, it's been just Vaseline, or they think picking the stuff off.
I was curious. This is Philip. You answered it sort of, but you said that the healing time is really long.
Yes, I've seen some of the smaller ones that don't really grow, stay small and go away in a couple weeks, if they keep them covered and take care of them. Some we've seen that have had wounds that they've been dealing with since last November, that just won't heal. They're just in various stages. Part of that is not the inconsistency with the wound care. So they kind of start getting better and then maybe fall back some and kind of all over. So that's been pretty inconsistent depending on the person, really, but some have been months, and it's kind of a very long term. That's why the infection usually will set in eventually, because it's very hard to keep a wound cleaned for months at a time.
And do you think that's like in people who are also continuing their substance use? And
Yes. So that's so if they're still putting xylazine in their body, these wounds are likely not going to heal. At that point, we're likely just trying to keep infection away. But they're going to be very hard to actually heal them and allow them to really get that blood flow back and make the new cells. This is the first time that I've ever seen an adulterant in a drug that's making people want to stop. They're like, they don't want it anymore. And I just encourage people to get off of the illicit opioid supply. I'm not going to tell you what else to do with it, whatever. But it's poisoned and it's hurting you. And that's really the only way to get these wounds to go away, is to do your best to stay away from that supply. Unfortunately, here in Pittsburgh now, I think because Prevention Point keeps a good and bad batch list, there's like nothing that's testing negative anymore.
Wow.
And the test strips are great, but if you don't have a backup supplier or anything like that, then you're still going to likely use it if that's your only supply. You might get a head start on the wounds if you know that your supply has xylazine and you're taking it, and kind of watch out for things a little bit more, but it's not always avoidable. That's just where the supply is.
Thank you, Emily. Lee Shepherd?
Howdy, can you hear me?
Yep.
Yes, we can.
Okay, maybe I'd missed it. And I guess it's a two-part question. Is there any sign of, whether or not people are just getting this in their regular everyday dose and are doing it, injecting, smoking? Like, is there any sense of whether it is being injected more or being smoked more? And if there is there any difference in bioavailability? And then is there any difference in, development of these adverse symptoms?
I don't have hard data on that, but just from experience with like anecdotal with participants, injecting is definitely, they're getting more of them and they're showing up more. It's just people that are snorting or smoking are still getting them, so we can't say that it's directly related to injection of any sort, just the injection process. But I do have less. I rarely see people that I'm like, what methods do you use? And they say that they're smoking and then they're covered in them. So it does seem to be definitely more prevalent with injecting, but really just making sure that people know that. I've had a lot of people trying to encourage them to go smoke instead, just because if they have access to smoking supplies, just because it's people are injecting into the wounds and putting that directly into the because they have nowhere else to go, I think is why, and they think that there's some kind of venous access there because they can see blood and see tissue, but it's still not venous access, and it's really just like muscle popping it directly into a wound, and that can be pretty dangerous. So I have encouraged a lot of people to try to switch to smoking if they have those things available, and having some education on how to switch to smoking if they're I think smoking is about 80% bioavailability of injecting, so there can still be a good rush to it. It's a little easier for people, and it's also a lot easier to control your dosing, since you can kind of take a hit, wait a little while, see what's going on. So I highly recommend switching people to, if they're willing and able.
Well, I see. We had a question in the chat from Christine. She said, if you don't have access to MediHoney, is there another debridement method for patients to use on the street?
So just the petroleum will do it. Zeroform is helpful just because it's easier to apply. I think that's why we end up using it quite a bit instead of just slapping some Vaseline on there, because it comes in sheets and you can kind of nicely lay it inside the wound bed. And it's fairly affordable if you have access to wound care supplies. It's not too bad. The MediHoney, yeah, the Vaseline should be fine. It might not work as quickly as MediHoney. We had one patient who got Santal, which is like an awesome debriding agent, but it's very expensive and usually only used in the hospitals. But he was in for something and he got some of that and he said it worked wonders and it like got rid of that dead tissue so quickly. But that's really not a sustainable thing. I don't think we could really handle the volume of that we would need. But just with the Vaseline and keeping them moist and covered, and being consistent has been enough for a lot of people just to get that stuff off of there. We have had some that maybe don't get care for so long that if they do go to the hospital, end up getting surgical debridements, because the hospitals aren't really sure what to do with them. And if they're big enough, it's sort of like, okay, yeah, we need to actually get this dead tissue off of there and get rid of it. So that's not too rare, actually. We've got a lot of people, I think just more because the hospitals don't know what to do with them. There's lots of other MediHoney type things available too, like different kinds of medicated honey that you can get on Amazon. I haven't really messed with those too much, but they're probably a similar thing that would be okay. Hydrogel as well is one that I actually just ordered some because I want to give it a try with some folks because it's a little more, it's a little easier. It comes in these nice little thingies. that squeeze out, like a little accordion kind of push thing. But we'll see. I'm not sure about those.
Phil, would you like to answer that first question about showing up in other substances?
Woo. Halo, yeah, I was just typing an answer to that. No, so far it has only shown up in together with fentanyl. It's being added at the retail level versus the supply level, so it's happening in specific, whatever neighborhoods or cities or like regional, whatever that is. And the only in the amongst the drug checking programs, the laboratories in the state or in the country that have been working with the harm reduction programs, the only time that it's been seen in other drugs, fentanyl was also present. So it pretty much probably got there because of the fentanyl and not as something that some random addition. What in of the samples that we've tested found to contain xylazine so far in New Mexico, one of the samples was a counterfeit pill that all it contained really was xylazine and acetaminophen, the only active ingredients, with some trace fentanyl and fentanyl precursors. So whoever mixed that together and then pressed it into pills, that was probably the scrapings at the bottom or from the corner, and it didn't really have much of the fentanyl in it. So
Another thing I want to touch on too is overdose reversals, how they're quite a bit different. So because it is usually with the fentanyl, you still would use Narcan. What we're seeing though is too many people are just that people aren't waking up. So you give them Narcan, their breathing might return, but they're not going to wake up. So we see that a lot of like EMS or by other people, whoever's doing this, will start pumping them full of Narcan, and that's not necessary. If the breathing returns, the Narcan has done what it needs to. They just need to be monitored in case that breathing goes back out. And monitored for their safety as well. So they need to be laying in recovery position, which is kind of on the side, so that all of their limbs and everything are getting proper flow. We've had people that have passed out for hours and hours and hours and lose blood flow to a whole limb just because they're laying on it for so long. People can get assaulted and their stuff stolen. So just kind of making sure someone's in a safe position if they don't have someone to stay with them. But yeah, if you're reversing an overdose, if you see that breathing, getting a pulse ox is good because you can kind of make sure they're still getting that oxygen that they need. If you have access to actually providing some oxygen, that's great. But yeah, usually you don't need to pump them full of that Narcan. When they wake up, they're going to be very, very sick. There was another one too. You said is that Christine?
yeah.
Barbara?
There. Yeah, so the Vaseline, you just need something in between the gauze and the wound bed to keep that moist so it doesn't stick on there. Vaseline is usually sufficient. You don't want it to go, it can get on kind of the borders of the wound, if that's okay, but you don't want it to get too sloppy, like the Xeroform and the Vaseline and all the ointments around the healthy skin that you might be covering. We run into that where people have multiples, so it seems easier just to like slap a bunch of the ointment on a gauze pad and stick it down, but then a lot of that healthy tissue is going to start getting broken down, and we don't want that to happen. Yeah, so it's really just keeping it within the borders and up to the edges, but not really over so much. But you want to, if you're wrapping them a lot, putting that really thin layer of the A and D can just help protect that skin. But it's not going to be kind of held down with that gauze, and it'll breathe more since it's not going on the wound bed.
And vomiting post resuscitation.
We have heard some of that, but that's something that happens with overdose reversals anyway. So I haven't necessarily noticed a change in that. Really, because people, I would feel better if they would throw up. I know that something would wake them up. But yeah, it's more of just the sedation. That's the issue.
And Lee had a hand up.
Yeah, I had a question, and I know that the field is kind of a little different, but with fentanyl overdoses, I know that when we do reversals with Narcan, there is a really great reason to stick around afterwards, because they could always overdose again. I know that there's not currently a reversal for xylazine, but is there any such similar thing when you're coming upon, maybe someone who's coming out of an OD, if they don't dose again, is there a chance that they will again? Is that known?
If there's a chance that they would go back out again.
Yeah.
Yeah. So if the fentanyl, by the time most people wake up, the fentanyl is actually out of their system, and they're already in withdrawal because they're staying sedated for so long. I don't know of any that, like the xylazine itself, where they've kind of gotten up and been fine and then not redosed and then went completely unconscious again. But yeah, that's not something I have seen or heard about.
There have been, it does create its own tolerance and dependency independent of the fentanyl. So it's been creating a lot of complications with detoxing folks. And it is, like, I think from what I understand, the symptoms from it, including the, elevated heart rate and all, the nervousness and all the things, like, really starts to come on just as they're getting over the fentanyl part of it. So like on day 3, day 4, that's my understanding of it. So
yeah, we've had some people who might be like in the ER or something. They get the opioid withdrawal handled and then go about their whatever and get discharged, and then later on at home start feeling these withdrawal symptoms from the xylazine. And it's been described to me as more anxiety driven. It's like a panicky kind of feeling, with rapid heart rate and things. So it's scary for people for sure.
I got a few more questions in the chat.
Okay. On the question I'm answering to Casey, the materials will be available on the listserv. I'm going to put the address up one more time. And send, if you're not on said listserv, please send me an email. I'll put my email in the chat also again, and you can be added to the listserv. The next question is, in the case we had last week, the patient's question was how to stop it from growing. How would you answer that question?
I don't know that there is a way to make it stop growing. I would think the first thing to do would be to try your best to stop putting the xylazine in your system. That seems to be what's, kind of exacerbating some of them, and if they're just continually putting that in. But keeping the moist around the edges and doing the proper wound care could keep it from more tissue from dying and kind of get it to start healing the right direction and not going the others. But yeah, I don't know if there's any way to really make it stop other than not putting in more xylazine in and giving it a chance to heal.
Go Taryn.
I kind of have a quick question for you, Tracy. Is this something that we might be able to supply our clients with, like the wound care stuff? Is that a possibility that we'll be able to do that? And then second question is if we're referring people to medical providers to kind of get this stuff taken care of, Emily, I don't know if you know, Roswell is very small, conservative, and very rural, and our providers are not very helpful to our clients. Like I recently just had a client who was experiencing chest pain, and they did a drug screen on our client, and they told her, well, if you quit doing meth, you won't have chest pains. Mind you, she's on all sorts of different medications just for her health. So we kind of experience a lot of like stigma amongst our providers. how can we help advocate for our clients
Um,
and getting
so
them the supplies they need?
I've been trying to, if I am referring, and I'm pretty sure they are going to go seek this further care for these wounds or for whatever, giving them information to take to their provider. I actually have a provider handout that kind of breaks it down with provider information so they can advocate for themselves when they get there. Like, hey, this is likely what this is. They would have to be open about their use to really get to know, to be able to say that this is what this likely these wounds are or this problem is. Um, yeah, I'd be a millionaire if I could figure out the stigma problem with drug use. So
Yeah.
I don't-
Is there
As-
any way to get access to those provider packets that you give
yeah,
out?
yeah, they were some kind of shared document, so I can attach those too.
Okay.
I've had
As-
also like, here at my hospital that we work at, we have a wonderful Center for Inclusion Health that is embedded within the health system. And we do a great job with managing pain and withdrawal symptoms and things like that when people are inpatient. I'm still having a hard time getting it through to like ED nurses to train them, and no one wants to hear it, and it's so frustrating. So sending those resources and just saturating the community with more information, somebody's going to see it somewhere and start talking about it and start
Mm,
talking to their colleagues and things. So really, if you have anyone that you can get flyers hung up in the break rooms, just anything that'll get people talking about it, and asking questions about it. If you can get to like nurse managers, charge nurses, things like that are in charge of like the education and continuing education, you likely have a better chance getting through to some nurses than doctors likely. Um, but some care. They will look into it and have a
as
more
far
chance.
as, I'm
Sorry,
sorry.
go ahead.
As far as the supply, I just got a shopping list from, thank you, Emily. I now have a shopping list for supplies that we can offer on our
Good.
supply website. I'll be reaching out to Dan and Ryan pretty soon with Josh, and we'll walk over what we can supply, to our clients. And we're going to do as best we can, and get as much of these materials out into the field or through our providers too as possible.
Thank you.
I think, yeah, we started when I was with the Mountain Center previously in, 2020, I think fiscal 21. I spent 2/3 or more of our budget for extra things like wound care supplies and all that by August. Right, and that was before any of this happened. So
Yeah. That's another
yeah.
reason saving the Meta Honey for like the actual ones that need a lot of debridement and not
Hmm.
just kind of throwing it in kits that you would give to anyone kind of thing will save on the money because they really don't. Not everyone needs the Meta Honey.
Thank you for that, Emily. Again, I've gotten so much information from you in order to help out, our clientele. Are there any more questions?
I'd just like to add, there's a question in
Oh,
there. The strips have been ordered. I asked last week, and we're just waiting for the delivery. And as soon as that happens, which will hopefully be by the end of this week or early next week, then the harm reduction programs can stop.
Do
So
you know what brand of strips you're getting?
we're getting the BTNX ones
Okay.
for starters.
thanks, Phil.
Yeah, what I was going to say, one of the individuals who brought in one of those first 3 samples had experienced one of those wounds that, was a bruise, and then it opened up, and but she had been treating it with soap and water at home, and it did heal at that point. I'm curious if I know most of the people that like we have all seen on TV in other parts of the country where this is happening seem to be mostly folks experiencing homelessness. have you also seen other people accessing services and things, or do you know if that's something that has been appearing more often in hospitals and stuff where you are, and in Philadelphia and places like that?
So as far as the hospitals, I think people are going when they get so bad they don't know what to do about them anymore. So they're pretty severe if people are going to the hospital for that reason. A lot of times sure someone could be in there and have a bunch of xylazine wounds, but no one's assessing for them, and they're not necessarily there for a complication with the wound. So they probably catch a lot of them smaller like that, but by the time they get to them, they're so bad that they have to get some kind of treatment for them. I think it's, one of our sites does not actually have a huge population that experiences homelessness. They're like more rural, and but they do have housing and access to running water, and they still get them too. I think there would be the same kind of implications for all homeless wound care, where it would just be a matter of keeping it consistent and keeping it clean a little more. We do know too that the Meta Honey, though, for homeless folks in the summertime can draw bugs into tents and things. So it's something to think about if you are using that if they're keeping, you don't want to spill it all over the tent and things like that.
Right, because yeah, thinking about so many of the folks we serve are like that in rural situations. There's just as many, or I think more probably, where people who are accessing services, have access to water and all that kind of stuff. And so I'm wondering, like, was wondering what that looked like, sort of in the middle class folks.
Yeah.
Are they experiencing that kind of stuff at the same rate? So
Yeah, my interactions, I don't necessarily assess housing in the setting that I'm in. They come to us at the mobile sites, so we're kind of going to neighborhoods, and then people come to us. So it's not always totally sure. But our street medicine definitely sees them and has they have a lot of complications with them.
Okay. One last question from Bernie.
we have one in the chat too. So
Oh yeah. Okay.
I don't have a question. I just wanted to say that for anybody who's on the call who's not a harm reduction program provider or subcontractor, I don't know how you guys are doing that in terms of distribution of the XGS, but I ordered from BTNX this week too, and they're supposed to get here today or tomorrow. So if you're not a harm reduction provider, I too can provide you with free FTS and XTS, and I'm working with Philip in the harm reduction program so that we have the same handout messaging on the XGS, so that we are having. I actually ordered BTNX because DOH was, so that we would have community consistency.
Good.
Thank
So
you.
people on the call know that. Thanks.
Okay. No problem. Thank you. And there's a follow-up question. Do they know when or why it stops growing in the absence of xylazine? Is growth completely tied to the continued use of xylazine?
I don't think we really know, because there's no way to exactly gauge that. But I do see that wounds start to heal when people do stop putting in the street opioid supply. It gives them a chance to. So if you're continually putting in, it's just going to keep with that vasoconstriction, and those areas there where it's already dying, that death wants to grow, if that makes any sense. So it will just keep dying in that. So at least if you're not putting the xylazine in anymore, your vessels might start opening back up. You might be able to start getting some blood flow to those areas to get them to heal a little more. So that might stop the spreading of the dead tissue. But I, without knowing exactly what's in everything and exactly how people are taking care of them at home and things like that, I wouldn't be able to really say.
Okay. And another question, and it should be, hopefully it's the last, of course not. What about the weather this summer? Is going to be really hot. Do we have any protocols for those who become unable to move in the heat, like covered areas or giving people access to shade and water?
Is that one for me?
Yep.
Oh, so in the summer, yeah, it's harder to keep them covered. That bandages tend to help with that. But I mean, that would be depending on your access to water to supply to those people. I'm not sure. But there are ways to clean wounds and things. You can give them some supplies that they can do those things without running water and still get a a clean wound dressing on.
Mhm.
That might be something, but people are going to be wearing more shorts and t-shirts, and these wounds will be more exposed. So keeping them covered with bandages is going to be more important. In the winter, at least, sometimes they're still covered by clothing, so they're not getting as exposed to the elements. But yeah, that's tough. People will get hot with bandages on all the time as well.
Sure, absolutely. Um, okay, this sounds like it is okay. The communication between Christine and Casey, and they can deal with that themselves. If there's no more questions, I'd like to give you 3 minutes of your day back. But first, I wanted to thank Emily Baldwin for her time and her expertise and her experience and knowledge and sharing that with us. And I want to thank everybody for taking the time out to really be involved with this very, very important situation that's going to just increase in the coming months and years, unfortunately. But this is the first time we're starting to see it, so we want to be out in front of it.
Yep, you're doing great. Thank
All
you
right,
guys for
thank you.
having me.